morning again. First of all, I want to greet again the chairmen of this session and all of you, and thanks the invitation to be here. My talk will be about clinical nutrition in long-term weight management. And what is the optimal dietary approach for safe, effective, and sustainable weight loss in overweight and obese adults and in long-term weight management? As you know, we have various dietary approach with different caloric content, and macronutrition composition has been recommended to treat obesity. Although their safety and efficacy profile has been assessed in numerous RCTs, reviews and meta-analysis, the characteristics of the optimal dietary weight loss strategy remains controversial. So, we have various dietary plans: low fat, low carbohydrates, high proteins, very low caloric diets with meal replacement, Mediterranean Atlantic diets with intermittent energy restriction. We have many papers, many guidelines, many evidence or not, and dietary guidelines for weight loss vary greatly between different scientific societies and have been revised many times, reflecting the uncertainty in the field of nutritional management of obesity and the difficulty to generate uniform recommendation for all patients. So, first of all, we will talk about intermittent energy restriction versus continuous energy restriction diet. The first paper tells us both intermittent and continuous energy restriction achieve a comparable effect in promoting weight loss and metabolic improvements. Long-term trials are needed to draw definitive conclusions. In the second paper, intermittent energy restriction may be more effective in reducing body weight and improving some cardiometabolic risk factors in short term. Intermittent energy restriction was also associated with high rates of attrition and weight regain following cessation of the 6-month weight loss phase when compared with continuous energy restriction. And again, the authors state that future research is required to establish the factors affecting short and long-term acceptability of the intermittent energy restriction and how best to optimize dietary advice to facilitate long-term compliance and weight maintenance. A third paper tells us this paper is a systematic review and say that restrict energy, daily restrict energy or intermittent restricted energy is the same at long term. In the fourth paper, the conclusions are that there is insufficient evidence to support the long-term sustainable effects of weekly intermittent energy restriction on weight management. In this paper, what they did is the objective is to compare the effects of the continuous energy restriction versus two forms of intermittent energy restriction. One is a one-on-week of energy restriction, and the other is 5-2 program, during which participants restrict their energy intake severely for 2 days and ate as usual for 5 days. And they studied the impact on weight loss, body composition, blood lipids, and glucose. And the conclusion is that the two forms of the intermittent energy restriction was not significantly statistically different from weight loss, body composition, and cardiometabolic risk factors compared with chronic energy restriction. And a second point is, what about low carbs diets? What we know at the moment is that energy expenditure declines with weight loss, predisposing to weight regain. Little is, however, known about how dietary composition influences this adaptive metabolic response over the long term. And the objective of this paper, this work, is to determine the effects of diets varying in the carbohydrate to fat ratio on total energy expenditure. And always, it's a very short time, 20 weeks, and after a period of run-in diet, the patients were randomized to high, moderate, and low carbohydrate diet. And what this study had is that a low carbohydrate diet could increase energy expenditure during weight loss maintenance, and this metabolic effect could improve the effectiveness of the obesity treatment. But dietary composition seems to affect energy expenditure independently of body weight, but always, as other papers, additional research is wanted to confirm this. In this review of the current evidence about the emergence risk factors and potential safety concerns about low and very low carbohydrate diets, especially for high-risk patients, the concludes are that low and very low carbohydrate diets are not superior to other dietary approaches for weight loss. These diets may have advantages related to appetite control, triglyceride reduction, and reduction in the use of medications in type 2 management of diabetes. The evidence review showed mixed effects on low density lipoprotein cholesterol levels, and some studies showing even an increase of the LDL particles. There was no clear evidence for advantages regarding effects on the other cardiometabolic risk factors, and minimal data are available regarding long-term. There are no studies with a period lower than 2 years about efficacy and safety. These very well studied show that Mediterranean and low carbohydrate diets may be effective alternatives to low-fat diets. The more favorable effect on lipids with the low carbohydrate diets and on glycemic control with the Mediterranean diet suggests that personal preference and metabolic considerations might inform for individualized and tailored diet intervention. And in this meta-analysis, the relevance is that macronutrient-centered weight loss diets has been mainly substantiated by short-term studies, and the results may be influenced by inter-individual biology, behavioral difference, and different adherence rates. And, of course, again, we need long-term studies that fail to provide any robust evidence in supporting of the modulating dietary macronutrients and composition to achieve a better weight loss outcome. And third, what about the glycemic index? In this study, the results say that low glycemic index can have unmodest impact on body weight, body fat, blood glucose, and blood lipids, and it is not the dietary advice per se, but the implementation of such advice and its relation into daily life that is important for achieving weight loss. And what about keto diets? Ketogenic diets result in weight loss for those who successfully use this strategy to reduce overall caloric intake, but by limiting all carbohydrate-rich foods like breads, pasta, rice, cakes, and cookies. And we don't have long-term data on keto diets and on cardiovascular cancer and other chronic disease risks. They are lacking. And low carbohydrate diets has been linked to increased mortality. And nowadays we talk a lot about personalized nutrition. Should I eat according to my microbiota? Stratification of individuals according to two types of microbial enterotypes, Provotella or Bacteroidetes, predict response to diet and drugs. The enterotype potentially affect the individual's ability to lose weight when following a specific diet. A high-fiber diet seems to optimize weight loss among those with Provotella enterotypes subjects, but not among those with Bacteroides enterotype. In contrast, increasing bifidobacteria in the gut among bacteroids enterotypes subjects improves metabolic parameters, suggesting that this approach could be used as an alternative for weight loss strategy. So, enterotypes have the potential to become an important tool in the personalized nutrition and obesity management, but we need more studies about that. And does my olfact can influence what I eat? Yes. The results of this study suggest that the novel relationship between olfactory pathway genes, methylation signatures, obesity index, and dietary intakes. And the presence of the comorbidities can influence my weight loss. What is the ideal diet for people with diabetes and obesity? Diets with equal caloric intake result in similar weight loss and glucose control regardless of the macronutrient content. And the metabolic status of the patient based on lipid profiles and renal and liver function is the main determinant for the macronutrients composition of the diet. If you had hepatic steatosis, you have an increased risk of long-term weight regain. You could have individuals with hepatic steatosis compared to those without have a greater resting metabolic rate decline and height metabolic adaptation after weight loss, potentially increase the risk for long-term weight regain. And what about personalized nutrition? If the glucose metabolism can determine my weight loss, in this study, as you can see, at the end of 24 months, low-fat and low-carbohydrate diets put the same weight loss. But those that in the pre-treatment have fasting plasma insulin is associated with long-term weight loss on heavily with low-carbohydrate or caloric restriction, low-fat diets among people with obesity and impaired fasting glucose, but not in those with normal glycemia. So, fasting plasma glucose and insulin are strong predictors of the weight loss response to diet with a different macronutrients composition and might be useful approach for personalized weight management. And so, what is the scientific evidence for diets, for weight loss, different macronutrients composition, intermittent fasting, or popular diets? The aim of this review is to discuss the scientific evidence of 3 categories of diet for weight loss. The 3 main categories were diets based on manipulation of macronutrients content, low-fat, high-protein, and low-carbohydrate diets, or diets based on the restriction of a specific food or food, for example, gluten-free, paleo, vegetarian, vegan, or Mediterranean diets, or diets based on the manipulation of the time fasting. And the conclusion is there is no one most effective diet to promote weight loss. In short term, high-protein, low-carbohydrate diets and intermittent fasting are suggested to promote great weight loss and could be adopted as a jumpstart, but owing to adverse effects, caution is required. In the long term, current evidence indicates that different diets promoted similar weight loss and adherence to diets will predict their successful. And it is fundamental to adopt a diet that creates a negative energy balance and focus on good food quality to promote health. So, another question. Choice of treatment by the patient leads to a superior weight loss than prescribing a specific dietary regimen? No. There is no evidence to support the notion that given overweight or obese individuals, a choice of treatment leads to superior weight loss than prescribing a specific dietary regimen. No advantage or disadvantages to providing a choice in terms of participant retention on adherence of the treatment. We love guidelines. We have American guidelines, we have European guidelines, we have Brazilian, Spanish, and Portuguese guidelines for the treatment of obesity. Patients love diets, famous diets, diets made for famous people. Although there are dozens of weight loss promising to reduce body weight, the characteristics of the optimal strategy remains controversial, and no single diet strategy is uniformly superior to other in terms of weight loss, maintenance, and long-term weight management for the general population. Still, we have many questions. What is optimal macronutrient ration of a diet? Optimal macronutrient ration of a diet, fat, carbohydrate, proteins, has received significant attention in the past decades for its potential relevance in weight loss, but remains still elusive. To achieve weight loss and other health benefits, we must to emphasize this energy deficit, irrespective of macronutrient composition, macronutrient composition irrespective of caloric count, diet quality by means of naturally cooked and processed healthy food, irrespective of macronutrient composition or energy intake. All these approaches have their own rationale and are all evidence-based and partially correct. So, the key to successful weight loss lies in the prudent combination of all these approaches in the context of a health and balanced diet without severe restriction or nutritional exaggerations. But still, we have many questions. Not just what you eat, but when you eat can influence your energy balance. What is the influence of the circadian rhythms or metabolism processes? Can differential gender influence diet, the response to diet? A precision or a personal nutrition versus a public health nutrition? With a precision personal nutrition, one size doesn't fit all. But with a public health nutrition, global health strategy fits most. So every day we have new scientific papers come up, and about this, please, I want, okay. So, é o anterior. Yeah.
Tá, só uma pergunta, pão pode à vontade?
Pão é... Então, Solange, fiz aqui uma dietinha pra você. Queria que você tentasse seguir a risca, pelo menos nas primeiras semanas.
Tá, só uma pergunta, pão pode à vontade?
Pão é ótimo. Não leu o jornal hoje?
Você leu o jornal?
Sério? Peraí que eu vou ver aqui no dia onde você continua fazendo bem. Continua. Pode comer. Tá certo? Quando voltar a fazer mal, eu te aviso.
Aqui tá dizendo pra evitar brócolis?
A todo custo. Acabei de voltar de uma convenção do brócolis e brócolis, ó, caiu.
Não tem aquele negócio que o brócolis evita diabetes?
É, mas parece que tá dando Alzheimer, então você mesmo tem que botar brócolis.
E ovo pode?
Ovo pode à vontade.
Ah, não vai mudar?
Não, ovo veio vai ficar. E não, caiu, por causa do colesterol. E não, é colesterol bom. Pode comer. Tem um grupo do WhatsApp só pro ovo.
Deixa eu te fazer uma pergunta, não tem nada mais definitivo assim, tipo uma linhaça?
Não, linhaça tá super, ultra, mega proibida. A partir das 2 horas da tarde.
Ah, então não pode comer linhaça depois das 2 da tarde?
Não, não pode comer nunca. É que descobriram isso hoje às 2 da tarde.
E abacate?
Abacate mata.
Então não.
Germe.
Então
Ser
sim.
responsáveis pela cura do câncer.
Então não.
Mas o câncer é bom.
Vai ter câncer bom?
Não, esse é o problema.
Então não.
Não poderia, né, deixar de poder, a não ser que volte a não poder.
Então vamos fazer o seguinte, abacate não, né?
Então, Solange, fiz...
Okay, so but despite this, we have general principles. The general principle, the optimal diet to treat obesity should be safe, efficacious, healthy, nutritionally adequate, culturally acceptable, economically affordable, and should ensure long-term compliance and maintenance of weight loss, and should be realistic goals. And the key principles to facilitate weight loss and most important, reduce their overall cardiometabolic risk and obesity-related comorbidities. It is not possible to lose weight without a negative energy balance. A caloric deficit of 500 calories or more per day is a common initial goal for weight loss for adults. And as we said, energy restriction, the macronutrient composition of a diet that was originally thought to play an important role, could be have some importance for facilitate weight loss. Certainly, some kind of diets can promote satiety, burn fat, and preserve metabolically active lean fat mass. This we have to maintain realistic goals for weight loss. It is extremely important since the adoption of strict and difficult to reach goals may often lead to failure and discouragement. And behind setting realistic goals, long-term adherence to dietary intervention represents also a great challenge, since many diets are pursued for one short period of time, especially those with extreme restrictions leading to suboptimal long-term control. And even more important goal than weight loss is weight loss maintenance and prevention of weight regain. What are the predictors of successful long-term weight maintenance after initial weight loss? Frequent self-monitoring of body weight, medical supervision and psychological support, positive feedback, consistency of food intake, eating breakfast, low-fat intake, low intake of healthy snacks, high levels of physical activity. And diet-induced weight loss, it is a matter of quality or a matter of quantity. The optimal diet remains still under debate. One general principles and recommendations can be provided, and no single diet can be prescribed for all people with obesity or recommended as the best fit for all diets without strict individualization. The ideal weight loss maintenance diet should be continuous and easy to comply with. Health diet is both consistent, and a health diet is a varied diet rich in fruits, vegetables, whole grain products, high quality proteins, impure and added sugar, refined grains, and highly processed foods. Best diet is a diet that people can comply with for a long period of time without significant weight regain. And we have the key recommendations. You need to maintain a caloric balance over time to achieve a sustained and a healthy weight. Reducing body weight back to a healthy range requires significant effort over a span of time, even years and years. People who are most successful at losing weight and keeping it off do so through continued attention to a caloric balance. Although total caloric consumed is important for caloric balance and weight management, it is important to consider the nutrients and the health properties of food and beverage, as well as their calorics when selecting an eating pattern for optimal health. Limit the intake of sodium, solid fatty, added sugars and refined grains. Emphasize intake of nutrients-dense food and beverage, vegetables, fruits, whole grains, fat-free and low-fat milk and milk products, seafood, lean meats and poultry, eggs, beans and pies, nuts and seeds. Foods to reduce all of this. Reduce the salt consumption, reduce the saturated fatty acid and replace them for mono and polyunsaturated fatty acids. Consume less than 300 of cholesterol per day. Reduce the trans fatty acid consumption. Reduce solid fats and added sugars. Consumed with moderation the alcohol. And reduce or abolish intake of sugar, sweeteners or beverages. Foods and nutrients to increase: vegetables, fruit intake, and whole grains. Choose a variety of protein foods which include seafood, lean meat, poultry, eggs, beans and pies, and unsalted nuts and seeds. Increase dietary fiber. Soup is good and may lead to decreased caloric intake. Beans and pies are unique foods. They are excellent source of protein and they are vegetables as well. And because nuts and seeds are high in calories, they should be eaten in small portions and used to replace other proteins, foods like meat or poultry, rather than be added to the diet. Choose low-fat milk versus whole milk and make healthy choices. Monitoring intake, more aware of what and how much you eat and drink. See the nutrition fact label. When eating out, choose small portions and lower caloric options, or instead of eating out, cook and eat more meals at home. Empower individuals and families with improved nutrition literacy and cooking skills and preparing and consuming healthy foods. Eat a nutrient-dense breakfast. Consuming breakfast has also been associated with weight loss and weight loss maintenance, as well as improved nutrition intake. Replacing added sugars with non-caloric sweeteners, and the health benefits from seafood in the amounts recommended outweigh the health risk related to mercury. And the plantation of coconut oil, palm oil, all are saturated fatty acids and contain trans fatty acids. And building healthy eating patterns like DASH, food pyramid, Mediterranean, Atlantic, and diets plant-based. And the most important of all, address is more important than meal plan type for weight loss success. We, in the Portuguese Society for the Study of Obesity, we did practical advice for patients, and we did a guidance manual for people with pre-obesity and obesity. It is a book and is free on the site of the society. Thank you. Oh, no, the last one. What is the medical nutrition therapy in long-term weight management? Is a balanced diet forever. Thank you.